Assalamu alaikum, students. So today's topic is potassium homeostasis. Uh, Obviously, the focus is kidney. So we'll be discussing a lot about how the nephron handles potassium. And then later on, we'll talk about how the whole thing is regulated. Okay. Right. So we know that it is one of the most abundant cations in the body. It is concentrated inside the cell. So most of the potassium that we know is inside the intracellular compartment, and very less as compared to very less which is present in the ECF. Okay. So of the total of that potassium, we have in the ECF, we have 3.5 to 5 milliequivalents per liter. As I said, 98% potassium is within the cells. These are important definitions and important values to remember. Hypokalemia is decreased ECF potassium, and hyperkalemia is increased ECF potassium. Okay, the values are clear. Less than 35 milliequivalents per liter is hypokalemia, and more than 5 milliequivalents per liter is hyperkalemia. Something to note here, as you can see, this is a very tight range. It's literally in fractions. 3.5 to 5 is the whole game here. And a lot of mechanisms basically go into maintaining this very tight range of ECF potassium, and for good reason. And by now, I hope you remember the importance of potassium, not only in nerve action potential, but primarily cardiac action potentials. So it's crucial that potassium remains within a tight range because the heart and its conduction system, the whole thing, the whole working depends on a stable ECF potassium. So the main regulator basically of all this is kidney. That's why we're discussing this. There can be wide fluctuations in dietary potassium. So there are diets which are high in potassium, then there are diets which are devoid of potassium. You can have whatever you like, of course, within a normal range. So a normal person can have a diet maybe high in potassium, and the cells and the ECF potassium will eventually remain constant because of a high degree of regulation at the cellular level. So all the cells regulate their potassium, and also then the master gland, the kidney, takes care of whatever leftover disturbance there is left in potassium. So whatever the diet is, eventually it gets taken care of within, of course, within a certain range by the cells themselves. We call it internal regulation, and external is by the kidneys, which control so many other things. So today we'll see how kidneys regulate potassium. Right, so let's get to this first. So every cell basically deals with its own share of potassium, and these are the factors which affect cellular uptake of potassium or potassium leaving the cell. Okay, so these are the factors. A few are mentioned here: insulin and beta agonists, which are a specific class of drugs used for example, asthma treatment. We'll talk about this. These are also called sympathomimetic drugs. Then we have osmolarity, exercise, and cell lysis, which cause potassium to leave the cell. Okay. Remember, when you say cell, the potassium has gone into the cell, it basically means that now ECF, the potassium in the ECF will be decreased. Okay. Please remember this relationship. If potassium moves into the cell, there will be decrease of potassium in the ECF. And when there is net movement of potassium from the cell to the outside, this is like adding potassium to the ECF. So those values, remember, 3.5 to 5, they keep fluctuating by these factors. All right. And then you have a special case here, acid-base balance. We'll talk about this. Potassium and hydrogen are, let's say they are stepbrothers. Okay. They don't like each other. And we'll talk more about that. Okay. Let's start from the right, and we'll look at which are the factors which cause potassium uptake, and why is this case. So insulin basically increases, as you can see, the arrow is going inside, increasing potassium intake by basically stimulating sodium potassium ATPases. Now you remember what sodium potassium ATPase does. It pumps potassium inside and 2 potassium inside and 3 sodium outside. So insulin is known to stimulate that ATPase, and hence it pumps potassium into the cell. And this goes in nicely with the overall function of insulin, because insulin is that main hormone that gets released when you have food. So its job is to increase uptake of cells of foodstuffs, like mainly, of course, there is glucose, also amino acids, and also potassium. So it is envisaged that your diet will have potassium component to it. And since potassium needs to be maintained within a tight range, insulin is nicely designed to, while it's increasing the uptake of glucose and amino acids inside the cell, it also enhances the potassium uptake, so that the ECF potassium is not much disturbed by what you have ingested. And indeed, in disorders of insulin, so for example, the famous one, diabetes mellitus type 1, you get hyperkalemia. Hyperkalemia is increased ECF potassium because there is insulin deficiency, and hence the movement of potassium inside the cell, which was mediated, which was to be mediated by insulin, is not there. So you get you get hyperkalemia. So when this person would ingest unwisely a high potassium diet, he or she is looking into trouble of developing hyperkalemia. At the same time, if you have too much insulin, so if you have a tumor of the pancreas, insulinoma, which secretes insulin, extra abnormal amounts of insulin, then you can imagine that there will be hypokalemia, because a lot of insulin will abnormally put a lot of potassium out of business and into the cell, and you have hypokalemia going on in the ECF. Okay. The second potassium pusher inside the cell, if we can use that term, is beta agonist drugs. Okay, so these are there's a whole bunch of drugs that you'll be discussing in pharmacology next year, hopefully, inshallah. So there are beta agonists, then there are beta antagonists, then you have alpha agonists and alpha antagonists. You might want to get hold of a pen and a scrap sheet just in case you need to jot down some points. In fact, it's good that you do, because there'll be a lot of little bits of information that you would like to take down. I will try to put some of this stuff in the intro section below this video. But again, there are so many things that get said. Not all can be, I can't later recall all what I said and put it to the pen. So it's better that you jot it down, just like in a lecture. All right. So just as I mentioned, these are beta adrenergic receptors. They have agonists. When we say agonist, we mean something which stimulates this receptor. This receptor being a beta adrenergic receptor. So you know what we are talking about. We're talking about sympathetic related stuff. Okay. Then there are beta antagonists, which are not shown here. I'll mention it anyway. And the antagonists are basically, they work against these receptors. Okay. Similarly, alpha agonist would be some compound, some hormone or a drug which stimulates the alpha receptor, and alpha antagonist would be something which blocks it. Okay. Having had that very basic overview of what agonists and antagonists are, beta agonists, okay, they enhance potassium uptake by the cells. Okay, so they have a similar effect like insulin. Just remember them. They have they function similarly to the insulin in that they increase the uptake of potassium by stimulating sodium potassium ATPase. Again, just like insulin. These are sympathomimetic drugs, so they mimic sympathetic stimulation. Okay, on the drug side, these are type of drugs which you use in asthma, because they relax smooth muscle. So some background of these drugs, so that you just remember what they do in context of potassium. Moving on to beta antagonists. These are drugs, remember, these are drugs which block the beta receptor in the heart. And if you remember your heart physiology, if you block the beta receptor, you basically are snubbing the contraction of the heart. Why would you want to do that? Well, if there's a patient of yours who has hypertension, for example, or is getting angina, which is ischemic pain from the heart, you might want to calm down the heart by blocking the beta receptor so that sympathetic stimulation of this particular heart does not excite this heart too much because already it's in trouble. So propranolol is an example of a beta antagonist. And this basically does the opposite for when we talk about potassium. This does the opposite of what beta agonist does. And it basically increases, it increases ECF potassium by inhibiting its uptake by the cell. Beta agonists, they move potassium inside. Beta antagonists, they hold up potassium outside. So they cause hyperkalemia. If you are not careful with your beta agonist therapy of your patient, of your heart patient, you may get into a situation where you are facing hyperkalemia as a side effect of this drug. Okay. Then just a footnote about alpha agonists. They cause hyperkalemia, and alpha antagonists they cause hypokalemia. A way to remember is beta agonists are like alpha antagonists, and vice versa. Okay, enough about pharmacology. Now let's move on to classical physiology and discuss what hyperosmolarity is seen to be doing. It seemed to be smuggling potassium out of the cell. Now, how come it can do that? So just apply your simple physiological reasoning. Hyperosmolarity will basically move water out of the cell. So ECF has hyperosmolarity. The water will just simply pop out of the cell to equilibrate the hyperosmolar environment, simple osmosis, you know this. And while it's doing that, there are two ways to understand how come potassium comes into this fray. One is, well, if you transport water out of the cell selectively only, then that concentrates potassium inside even more than it is. So you have more potassium inside anyway. But now what you do is you take water out of the equation, thereby concentrating potassium inside, i.e. you even raise the gradient already present between ICF and ECF for potassium even more. So naturally potassium will start pouring out. This is one way of understanding this. The other way, a short way of visualizing it simply is that you can imagine the water physically dragging potassium out. However it works for you. So water movement outside of the cell responding to hyperosmolarity basically takes potassium out of the cell as well. Then we can see that cell lysis basically cell lysis means breakdown of the cell. So when do cells break down? There is normal wear and tear, okay, but generally cells are all right and they're there. Burns. So when a person gets burnt, obviously there is generalized destruction of tissues and of course the cells within and other fascia, etc., skin. So in this person will have an increased leakage of potassium outside of the cell, thereby creating a hyperkalemia sort of situation. Okay, so that's one real scenario. The other is a condition of skeletal muscle breakdown called rhabdomyolysis. Okay, in this basically skeletal muscles start to degrade, and them being cells, they are also packed in potassium. Potassium leaks outside and also then causes an ECF increase in potassium. Then you have malignancies, you have tumors, which are targeted by certain chemotherapy agent and other radiological treatments, which basically destroy these cells. Now, these cells at the end of the day are basically cells. They're malignant, but they are cells. And they are again high in potassium. When you destroy them, the potassium comes out and you have a hyperkalemic situation in the ECF. This is cell lysis. Exercise, it's interesting. Probably didn't notice or you never ever heard about this, that when you go into exercise, you get slightly hyperkalemic. So the potassium leaves the exercising cell, it goes out a bit, pours out. But when you rest out after your exercise bout, this whole potassium quote unquote disturbance settles down. However, there are important points here to note. One is, what if the person has a kidney problem? If a person has a kidney problem, especially a problem which affects his excretion of increased ECF potassium, then if you put this person to a hard bout of exercise, severe exercise, strenuous exercise, then the hyperkalemia will be significant and this will become a problem for this guy. So normally it doesn't. But if you have a compromised kidney, compromised potassium excretion, then you have a situation in strenuous exercise. Okay. Any other point we have left here? No, we are good. We are good. Okay. Now, a footnote. If you remember, we did. I didn't probably cover it with you in your first years, but you remember local blood flow control. In local blood flow control, you studied vasodilation theory next to oxygen demand theory. If you now remember, you must have read potassium as a vasodilator. So just as a footnote here, potassium happens to be that one of the potent vasodilators, and it has a significant role in local blood flow. Okay, so that's that. We have done this bit here, the things that the factors that cause increase movement of potassium inside the cell and or hypokalemia. And then we have situations where the potassium will leave the cell, causing a hyperkalemic situation. Now coming to the stepbrother example. I just gave this example. I just made it up. Please don't write it. This is just to show you, just to make a memory trace, that hydrogen and potassium move opposite. The reason why I said step brothers is just a casual way of saying that they don't like each other. Okay, there's sibling rivalry between them. So if you move hydrogen in, potassium cannot take it. Potassium will move out, and vice versa. Okay, if you pull potassium in, hydrogen will be secreted by the cell. Now you can imagine that this has a very significant effect on not just potassium homeostasis, but also acid-base balance. So the perceptive student will immediately make a scenario that if there is acidosis, there's generalized acidosis. So acidosis means there is high hydrogen ions. Okay. So, and before that, let me just give you a mainstay of this whole thing. It's that the body always aims to go for electroneutrality. So if you remove a charge, a positive charge from here and put it here, you can't simply do that. You have to replace either the same positive charge or a similar positive charge here where you took the positive charge from. So hydrogen is a positive charge, right? You took it and you put it inside for whatever reason. We'll discuss the reason. Now this hydrogen, it left here a bit of negativity. That's a big no in the body. So it will give out a similar positive charge to cover up the removal of this positive charge from here in the ECF. So always remember that electroneutrality is the mainstay of all of these interactions, and you will always remember to go with this concept. Don't cram individual bits. Try to make a concept. So electroneutrality is a concept. You will not need to cram this if you understand the concept. Okay. So I'll make a statement now. Acidosis causes hyperkalemia. Just hear it again. Acidosis, high hydrogen ions in the ECF, causes, i.e., it induces hyperkalemia, i.e., increased potassium in the ECF. Now, what's going on here? Now, if you just refer back to the concept of electroneutrality that I just mentioned, you can solve it. You can sort it out. How? When we say acidosis, we basically mean high ECF hydrogen ions, right? Basically, it involves hydrogen ions. If it involves some other thing causing acidosis, some other anion or carbon dioxide, then we are not talking about this. We are strictly right now talking about acidosis, which is caused by high hydrogen ions. This thing, what I just said, this will come in later as well. Okay, so you have a situation of acidosis caused by free hydrogen ions outside in the ECF. Okay, so what happens is the hydrogen starts going in the cell, because ECF pH is a very serious matter. The body designs the whole thing so that the pH does not fluctuate a lot. And you have all sorts of buffering protein, etc., inside the cell, which are not available in the ECF, which can buffer this extra hydrogen. The key is to remove it as soon as possible. So as soon as possible, you have a proton just roaming around, minding its own business. No, the cell wouldn't have it. It will pull it in a hydrogen potassium antiport mechanism. So the hydrogen gets inside, and very importantly, the potassium gets outside. So high hydrogen, which is acidosis, causes high potassium, which is hyperkalemia. So acidosis or results eventually in, if it's not handled otherwise as well by the kidney, etc., acidosis will cause hyperkalemia. Okay, so that's that. Alkalosis will cause, you guessed it, if you have less amount of hydrogen, the thing will reverse. The hydrogen will exit the cell, pulling in potassium. So as alkalosis causes hypokalemia. Okay, that's that. If you've understood all of this acid-base business that I spoke about, the hydrogen-based acid-base disorders, let me just re-emphasize, reiterate that this is hydrogen-based. If you have a respiratory acidosis or alkalosis, this potassium displacements will not feature respiratory acid-base disorders, because in respiration you have carbon dioxide as the main thing, and carbon dioxide, as you know, it moves freely within cells. Okay, it doesn't follow the principle of electroneutrality. Okay, uh, so that's one thing. If the acidosis is being caused by other organic acids such as lactate, keto acids, salicylic acid, which is aspirin, that also does not need electroneutrality by moving potassium. These organic acids, basically, they are negatively charged, of course. They are anions. They move along a cation automatically. So you don't need to disturb any potassium. So in summary, under acid base, the three things that I mentioned are the following. If the acid-base disorder is hydrogen-based, you will have a potassium disturbance which will attend it. Okay. If you have acidosis, you will have hyperkalemia. If you have alkalosis, you will have hypokalemia. Number two, if it's respiratory based, i.e. carbon dioxide based acid-based disorder, you will not have any potassium disturbance alongside, because carbon dioxide is freely diffusible in and out. It will sort of equilibrate itself. It doesn't need any other electrical movement to balance things out. Number three, I mentioned that organic acids such as lactic, keto acids, and salicylic acids basically move along positive charges with them, and you don't need to disturb potassium. Okay, so that's that. This is a comprehensive, I would say, overall explanation of internal potassium balance at the cellular level. Okay. Okay, so now we'll look at external balance, which basically means the way kidney handles, the nephron handles potassium. This is a busy slide. Again, I would advise you to keep a pencil or a pen and a piece of paper handy. You may want to take down certain points so that the whole topic gets prepared in one go. Okay, so there are three sections of this slide. One is the overall potassium handling by the nephron, some important bits here. Okay, the second part of this diagram is where we'll go through this section of the DCT. So a blown up picture of the alpha intercalated cell, which I mentioned in the previous slides, previous lectures. Principal cell, which I have explained in detail when discussing sodium homeostasis. And then we'll talk about the overarching regulation of potassium excretion, which has all sorts of factors in it. So saddle up. We start from the left. We look at the nephron as a whole. And you see the pattern here where we discuss overall chunks of potassium being handled very similar to what we saw in sodium handling by the nephron. But here the percentages are a bit different. This is the same, 67% potassium is reabsorbed at the PCT. However, unlike 25% that gets reabsorbed, sodium that gets reabsorbed at the thick ascending limb of loop of Henle, 20% of potassium gets taken up from here. Now, this is where again sodium got interesting, because this is where aldosterone does all sorts of things. when, excuse me, when sodium reabsorption, where we were talking about here, we see that when we talk about potassium, the diet becomes important, and then you have variable secretion. So reabsorption will take place if there is, if the diet is deficient in potassium. Secretion means that you are in your system, there is more potassium than required. So it's going above 5 milliequivalents per liter statistic. So you will have variable secretion, okay? And this secretion will depend on these five factors, which is, one is again diet, the other is aldosterone, third is acid base, then flow rate, and then luminal anions. Here I will just make a footnote. Look at the regulation chart here. You have physiological factors, then you have pathophysiological factors, okay? So under physiological factors, we say that these are the ones that keep a balance of potassium intake and outtake in routine. So this goes on in routine. You have the plasma potassium, which dictates whether there will be uptake, reabsorption of potassium, or secretion of potassium. You have aldosterone, which the details of which we'll be discussing soon. And then you have ADH, which also has something to say about potassium. It affects potassium levels in the ECF. Okay, you need to refer to ADH, the info diagram that I sent out. Then you have pathophysiological factors, which basically displace potassium balance. These are the ones that there are the issues which are not specific to potassium itself. There are other issues related to other stuff. So flow rate, as an example, flow rate depends on sodium, water, and whatnot. It doesn't directly link with potassium, but it has consequences for potassium. Okay, so these are factors which are unrelated with potassium homeostasis, but end up affecting potassium balance. Acid base, like we just discussed, also will come into play here as well, as it was discussed in the internal balance of potassium. Acid base again is not primarily a fault of potassium. However, it ends up disrupting a lot of potassium here and there. Okay, so this diagram can be read as physiological and pathophysiological factors as well. Okay, so having looked at the overall picture of what happens in potassium handling, and you can also see that excretion, if the person is deficient in potassium, he will only secrete about 1% of the total tubular load of potassium. However, if there is more potassium in the system, this can go up to 110% of secretion of potassium. And look at this value and correlate it with the plasma value of potassium of 3.5 and to 5 milliequivalents per liter. And you will see how serious a function kidney plays in the excretion of potassium, and how this is the main factor which holds the tight fort of plasma potassium. Okay, now then let's look at the tech. What is the technology which is behind all of this tight regulation of potassium? We see that you have the alpha intercalated cell. This is again alpha intercalated cell, and principal cells are two recurring cells, clusters, which happen to be along the DCT and a bit in the early collecting duct, if memory serves me right, but mainly the DCT. Okay, and if I may label this cell as a potassium reabsorber. So you can see potassium coming here as part of the same hydrogen potassium antiport mechanism that we discussed in the internal balance. It moves potassium from the lumen inside the cell, and then potassium is transported across the basolateral border and into the blood. Okay, so this is a clear-cut reabsorber of potassium. However, the principal cell, as you can clearly see, is a potassium secretor. It's a potassium secretor. So reabsorption of potassium and secretion of potassium. You will say, hey, what's going on here? These cells seem to be contradicting each other. Well, it's not, the word is not contradiction. The word is balance. So check this out. If you have deficient potassium diet, if you are on a low potassium diet, then you will have potassium reabsorbers, the alpha integrated cell, doing most of the business. Okay, because that's what you need. Your diet is low in potassium. You cannot afford to excrete any more potassium than you have to excrete. Okay, so you will reabsorb most of the potassium that comes the way of the DCT. However, and then this secretion will be, it will be snubbed in this scenario. However, if you are high on a high potassium diet, then what would you know? What would you be doing? You will decrease this, the working of this cell, and increase the secretion by the principal cell to get rid of the extra potassium. So you now understand what is the overall function of an alpha integrated cell and the overall function of the principal cell. One is reabsorber, one is secretor. Now, let's come to the bits here. Let's come to these things now. First, we'll look at the diet. We have mentioned the diet, but let's see if we have missed on something. Before I go into this whole thing of what the DCT does with potassium, whether it's alpha integrated cell or principal cell, I want to just clarify one basic golden criteria in potassium handling of the DCT. Always remember that it's all about the potassium gradient within the cell. And when we're talking about basically the principal cell, which is the secretor, because look, we're talking about secretion now, basically. So we are talking about primarily the secretor, the principal cell, okay, which comes into play when you have more than what you can handle in terms of potassium. So it's all about the gradient. What is the gradient? The gradient is established by the ATPase at the basolateral border, which keeps on pumping potassium inside and sodium outside. So it keeps on concentrating potassium here so that it can be promoted. The secretion can be promoted. Now, whoever and whatever compound or whatever phenomena going on in blood or wherever will stimulate this ATPase, will add to the concentration of potassium inside the cell. And this gradient will be enhanced. Remember, it's all about the gradient. When this gradient will be enhanced, naturally, the secretion will be promoted. So with that in mind, let's look at these factors. So one is diet. Basically, diet, again, it basically enhances the gradient across the DCT cells. And remember insulin that we talked about? So insulin also works on these cells. It enhances the ATPase. It pushes in more potassium, and hence it gets secreted from the luminal border. Okay. So this action, it's an interesting point. An add-on would be the effect of insulin, which we've discussed in the internal balance. Number two is aldosterone. Now, remember, aldosterone is a busy hormone. Aldosterone gets secreted by angiotensin 2. We know when angiotensin 2 is made, the whole renin pathway. So keeping that in mind, let's just pick up proceedings from aldosterone onwards. Aldosterone, basically, what does it do? Aldosterone reabsorbs sodium, and along with it, it reabsorbs water. This is what we have done up till now, okay? Because we've been discussing volumes and osmolarity and this, that, the other. But we've studied that. Now we've moved on. Now you see that this sodium uptake by this principal cell, it's a positive charge, right? Sodium is a positive charge. So is potassium. Now imagine this. If you pull in by a hormone called aldosterone, you're pulling in more sodium, okay? Which wouldn't have been the case if aldosterone wasn't there. But now that aldosterone is there, Aldosterone will, if you have been doing your reading, will induce the formation of and increase the insertion of ENaC channels, epithelial sodium channels, ENaC, ENA for sodium, C for channel, ENaC channels along the luminal border of the principal cell, thereby increasing sodium reabsorption by this cell. Sodium gets more over here, okay? Now this sodium will repel the potassium. When it repels the potassium, that will aid to, in addition to the gradient you have already established for potassium, this sodium pushing in extra will electrically repel the potassium and aid its exit along with the gradient which we already talked about. So incoming sodium is actually linked with outgoing potassium. Said it another way, sodium gets reabsorbed by aldosterone, and aldosterone also causes potassium secretion. This is new knowledge. You might want to log that away. Sodium reabsorption, potassium secretion done by aldosterone. Now, you can have all sorts of scenarios which we will discuss, and maybe some will come in your assessment based on this effect of aldosterone. Now, aldosterone, besides inserting ENaC channels and making available these channels for sodium entry, also tends to stimulate ATPase. So it maximizes the effect of potassium secretion as well as sodium exit along the basolateral border. So number one is ENaC channel insertion. Number two is stimulation of ATPase. It also, by the way, a third lesser mentioned effect of aldosterone is it also increases the number of potassium channels along the luminal border. So not just ENaC sodium channels, stimulation of ATPase, but also increased in the number of potassium channels through which potassium can be secreted. Okay. So we have established the sodium-potassium linkage as far as principal cell is concerned and the effect of aldosterone on this linkage. Okay. There are two more interesting points here which go a long way in increasing the depth of your knowledge about not just this cell, but also potassium homeostasis and how it's linked with sodium homeostasis. So these two things are, number one, sodium diet. So effect of high sodium diet and low sodium diet has an effect on potassium secretion. And number two is diuretics. We'll do it in this order. So once again, we are just commenting on the sodium-potassium relationship as far as principal cell is concerned. And in this, we'll first mention the sodium diet. If you increase the sodium diet, there's more sodium which comes in the DCT here, and hence the delivery, the reabsorption of sodium is enhanced, which basically tends to push more potassium out. So let me just give you the context. If sodium is normal, potassium is normal, everybody's happy, nothing doing. No potassium disturbance is seen. However, if you start increasing intake of sodium exclusively, what will happen? What will happen is this extra sodium will obviously bypass the PCT. This whole statistic remains true. However, you have just increased the tubular load of sodium, right? So it goes here and then it comes here. When it comes here in the principal cell, this is what happens. You have more sodium coming in, hence you have more potassium going out. What happens to the body? What happens to ECF? If your answer is hypokalemia, you are right, sir. You are right. So a high sodium load in the DCT leads to higher uptake of sodium, which leads to higher potassium secretion because they are linked. I keep repeating this. They are linked. Sodium reabsorption and potassium secretion, they are linked. You increase the reabsorptive load here, you increase the potassium secretion. So what will be left here is less potassium. Hypokalemia. Same goes with now number two, we mentioned the effect of diuretics. So there are two main diuretics. I'll be doing a separate video on diuretics, but an important point here needs to be mentioned. The diuretics, basically the thiazide and the loop diuretics, basically they work, the loop diuretics work on the loop of Henle, mainly the thick ascending limb of loop of Henle. And you remember what there is the main important symporter is sodium potassium 2 chloride symporter. We did that in concentration of urine, if you remember. So furosemide is a loop diuretic. It blocks this symporter and increases the amount of these solutes in the lumen. Okay. We have thiazide diuretic, which affects the sodium transporter in the proximal DCT, where there is no principal cell. Principal cell is in the later half of the DCT. In the proximal DCT, you have simple cells reabsorbing sodium. Thiazide diuretic blocks that, and loop diuretic blocks the symporter of the thick ascending limb of leucophenolate. Basically, both effects will lead to more sodium in the lumen. Yes, you see a pattern now. It's exactly the same that we talked about the high sodium diet, which means that when you're using these diuretics, you will increase the delivery of sodium in this lumen next to the principal cell, which again will enhance the sodium uptake and lead to more potassium being secreted. Now, the clinical addition here, the clinical point, additional point here is, if you're using a thiazide or loop diuretic, your patient will end up losing potassium. So you need to be very aware that if you have to use thiazide and loop diuretics in your hypertensive patients or your cardiac failure patients, why would you want to use the diuretic? Very quickly, to lessen the fluid in the cell, to get rid of extra fluid from this guy, so that the cardiovascular system, which is under load of extra fluid, gets relief. Hence the heart preload goes down, the heart also gets some relief. So diuretics are a mainstay therapy of hypertension and cardiac issues. That's why we are talking so much about diuretics. So these thiazide and loop diuretics do not make a point of conserving your potassium. This is like a huge issue. One is your cardiac patient, the patient is cardiac. Two is the choice of drug that you've used is making potassium disappear from the system, hence making this guy hypokalemic. Hence, you need to think about replenishing this person's potassium when you put him on these particular class of diuretics. And before I zoom out of this particular point, let me just say very briefly that there are potassium sparing diuretics which spare potassium. Okay, so more in the video on diuretics. That's that. Then we come on to we'll come on to acid base at the last. We'll just sort out flow rate. So flow rate is basically increased velocity of fluid through this system. So imagine that there is a normal flow rate through which the fluid flows through the nephron, and then there is an enhanced or increased flow rate due to whatever ECF changes, higher volume or high sodium presence in the CVS will cause more enhanced GFR, increased tubular load of fluid, and then increased velocity eventually of this fluid passing through the DCT. Now, if you have an increased rate, now imagine this cell right here, okay, with its inherent basic gradient for potassium ready, secreting it already, and it's happy right now with a normal flow rate. Now you enhance the flow rate, you increase the flow rate. What are you doing? You are displacing fluid from here more quickly than the cell would like. So the gradient, imagine the gradient, would it across this luminal border, would it be enhanced or would it decrease? You have increased fluid velocity. So fluid is being cleared of this area, i.e. in front of this audience of potassium waiting to be secreted. It's getting cleared off quickly, more quickly than it usually does. It will enhance potassium secretion, because whatever potassium secretion that occurs, for example, now potassium is being held up here at normal velocity. At higher velocity, it will be cleared very quickly. So there needs to be more potassium, and then more potassium, and then more potassium. So flow rate enhances, increased flow rate enhances potassium secretion by aiding this gradient, i.e. clearing the potassium off from the lumen quickly, which then forces the gradient to enhance itself and release more potassium. This is how flow rate affects potassium. And finally, you have the acid-base balance. And acid-base balance, apply the same understanding that we had in here in the internal acid-base balance, that if you push hydrogen in, you'll have potassium out. This thing just put here at the basolateral border. Okay, just imagine this now. You have a hydrogen, a hydrogen potassium, a symporter situation. I beg your pardon. Let's look at this, the apical, the luminal border. Okay, you have the symporter right here. I did not notice it before. Okay, now when you have acidosis, you have acidosis in the blood, right? The ECF is represented by the blood and the interstitium of the cell. This side is the urine side. This side is the blood side. So when we say that the body has gone into, say, acidosis, we're basically saying that this blood and its next door neighbor, the interstitium of this cell, have become acidotic, i.e., they are more in hydrogen. So what happens? More hydrogen will be secreted inside the cell. Yes, more hydrogen here, it gets secreted into the or put inside the cell. It gets secreted out because it needs to, it's acidosis. But then what happens to potassium? Potassium then gets reabsorbed, doesn't it? Because for electroneutrality reasons already explained. So this will result in, as I mentioned before, hyperkalemia. So hydrogen will move this way, potassium will move this way, and it will cause hyperkalemia, retention of extra potassium, where the original problem was with acid. It wasn't potassium's fault. The original issue was with increased hydrogen, but potassium had to come in because of the electroneutrality clause, and that's that. And you can work out what happens in alkalosis. It's the opposite. Okay. Now this is a packed slide with a lot of bits of information, as you can appreciate. I would suggest you maybe have a look at this video maybe once more or something if it works for you, and certainly read up on this material. You can refer to Guyton and BRS primarily with a reference from Rhodes, but mainly it's really Guyton and BRS which have been referred in the making of this lecture. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.